My name is Jordan Smallwood. I'm the Chief of Allergy and Immunology at Nemours Children's Hospital in Orlando, Florida. And today I would like to talk with you about the do's and the don'ts of allergy testing in the primary care provider's office. I have no disclosures for this talk, and our objectives are listed here. Allergy testing is a topic that's very near and dear to my heart, not just because I am a licensed allergist, but also because I know how much they can affect the lives of my patients and their families. Already, approximately 1 in 5 people will alter their diet on the basis of their own perceived symptoms of an adverse reaction, especially to foods, even without the assistance or advice of a medical provider, while only 3 to 5% of them actually would have some sort of clinical immunologic response if they were to be exposed to that allergen again. Moreover, in the past 5 years, I have seen an increasing number of primary care providers and subspecialists who are using allergy testing in their office to try and assist in the diagnosis and treatment of their patients. While good, we know that allergy testing is an imperfect test and false answers, particularly false positives, can and do happen. This leads to inaccurate diagnoses, which can then lead to unnecessary removal of foods from diets, unnecessary removal of beloved pets from the home, and multiple other lifestyle changes that can result in social, emotional, and nutritional concerns for your patient and their family. So when you consider performing allergy testing in your office, my first thought is that you should perform allergy testing if you are concerned that your patient's symptoms are truly allergic in origin. Now, we are all hopefully familiar with the basic symptoms we would expect for a patient who is having either environmental or food allergies, so I won't belabor that point. But you do want to make sure that after having met with your patient, hearing their history and performing a physical exam, that you are convinced these symptoms are likely to be allergic before you proceed with allergy testing. I would encourage that you avoid performing allergy testing for generalized symptoms such as vague abdominal complaints, headaches, fatigue, or muscle complaints. Likewise, I would ask that you avoid or think twice about performing allergy testing if you simply don't have the time to take a full allergy history. We are working at a time in medicine where physicians are being asked to do more with less and to see more patients in a shorter amount of time. And while I respect that, if you simply do not have the opportunity to take a full allergic history, I would ask that you not perform allergy testing at that time. Remember, this is designed to be a confirmatory test based on your suspicions from their clinical history, not to be the first step in diagnosis. Once you have taken that clinical history, I would encourage that you use that information to guide your selections for allergy testing. Often there can be a temptation to use broad allergy panels, both food and environmental, to determine what you should be looking for. However, I would encourage against the use of those. As an example, if a patient states that they had a perceived allergic reaction after a breakfast of toast, eggs, and orange juice, it's appropriate to look at wheat for the toast, eggs, and oranges. However, there is no need to be testing this patient also for milk, peanuts, soy, tree nuts, fish, shellfish, or any of the other foods if they were not associated with this reaction or if they have been tolerated in the past without any history of adverse reaction. It's also important that we understand the limitations of specific IgE allergy testing in the office. Specific IgE testing can have a specificity depending on what you are looking for of as low as 50%. In other words, you are hanging your hat on a test that has the same reliability as a coin toss. And therefore, it's important that you understand this limitation and don't simply assume that just because you have a positive test, you have reached the correct diagnosis. I'd also like to talk about skin testing. Though less of you may be doing this in your office or you may be hiring out through an independent contractor, there are some things that I think are important to note here as well. Now, as a licensed allergist, I follow the guidelines that are set forth by our governing bodies, in this case, the American Academy of Allergy, Asthma, and Immunology. And one of the first things that we make sure our patients do is they need to be off of certain medications that we know could interfere with allergy testing. In particular, antihistamines is a big one. We have a washout period of at least 7 days or more before we choose to perform allergy testing, knowing that these medications can result in false negatives if we don't. Other medications such as tricyclic antidepressants, clonidine, omalizumab can get in the way of testing. And there are more, and I would encourage you to look for a full list of those medications, but that's just a sample. Additionally, we always make sure that our patients have discontinued beta blockers prior to the use of allergy skin testing. We know that this testing can, in rare circumstances, result in anaphylaxis in the office. And if a patient is on a beta antagonistic medication, it can get in the way of the beta adrenergic activity when you administer epinephrine, thus making treatment of that anaphylaxis more difficult. You should always use a positive and negative control. That way, if you have a good positive response and a good negative response, then you know that you can lean on your results with more confidence. You should measure the wheal and the flare in millimeters. And for a response to be positive, remember that both the wheal and the flare need to be 3 millimeters greater in diameter than your negative control. Your negative control will set the bar for what is or is not positive. If a patient should happen to have a skin condition such as dermatographism, where simply stroking the skin can result in a localized wheal and flare response, it is probable that they will respond to everything for which you allergy test, including their negative control, which is why it's important to use your negative control to set the benchmark for how big the rest of the tests need to be in order to be considered positive. I prefer measuring in millimeters over using subjective interpretations such as stating something is a level 1 or a level 3. My concern is that if someone brings their results from a previous allergy testing to my office, I don't necessarily know what that physician or provider's level 1 is or a level 3. But if someone brings me a test that states that their wheal was 5 millimeters by 5 millimeters, I know exactly what was seen on that testing day, and it's very translatable to my office as well. I often hear a myth that children are too young to be allergy tested, particularly under the age of 4 years, and this is simply not true. However, it is important to note there are some things that younger children are less likely to be allergic and may not need to be tested for. Children under the age of 4 years can certainly be allergically sensitive to foods or to indoor environmental allergens, including things like dust mites, cats, dogs, cockroaches, or some molds. It is less likely that they have had enough seasonal exposure to develop an IgE-mediated response against outdoor environmental allergens such as trees, weeds, or grasses. Therefore, if a child is experiencing symptoms consistent with environmental allergies, it's still appropriate to test them, but you need to be looking more at your indoor and less at your outdoor environmental allergens. Beyond the age of 4, it's fair game to look for all of these things. And just as with blood allergy testing, I would always encourage you to choose what you skin test for based on the clinical history. Intradermal testing is a topic of discussion that's highly contested even within the field of allergy itself. But I would encourage that in the general primary care provider's office, you not provide intradermal testing. One of the problems that can occur is there can be an irritant concentration used with these allergens that results in a reaction at the skin, but that is not IgE mediated and can be misperceived as an allergic response when it really isn't. Additionally, I would ask that you not perform allergy testing if a patient is actively in respiratory distress. Skin testing can exacerbate conditions like asthma, and if a patient is already having trouble with their breathing, you should first treat their lungs and respiratory system, and once they're feeling better, bring them back in and perform allergy testing at that point in time. And of course, if after doing all of these things you are still uncertain or would appreciate additional advice, do refer your patients for further evaluation by an allergist. We consider it a privilege to be able to assist you in the diagnosis and treatment of your patients, and ultimately, we all work together on the same team to provide good care for our patients. Thank you very much for your time today.